Very good morning, doctors. I think we are good and loud. It's a warm welcome to all the doctors. So, most of the doctors are asking me, sir, you did not finish the neural system in central nervous system in physiology. Doctors, I will finish it. Why? Because I just give a gap. There is a reason for it, right? So, don't think like I will not go on with the neural system in physiology. See, neural system in physiology is one of the most important topic that you will be getting not less than 2 MCQs in the Inicet. So don't panic about it. I will finish the nervous system, and I have one more request to all the doctors. Some of the doctors are texting me like, sir, this topic is being missed in the physiology, that topic is being missed in the physiology. So they are just, see doctors, I just want to tell you one thing. Just go through each and every part of my physiology class. You just go through it, you just get each and every point in the video. Please go through the complete video. For example, even after going through all those things, if you just got a question, like if you think like I will miss some sort of topics, I am very much happy to welcome you to just drop it down in the comment section. For example, see, I'm not saying like that. For example, there is a topic like internuclear ophthalmoplegia. I know, for example, sir, you did not explain about internuclear ophthalmoplegia. Or for example, sir, you did not explain the multiple sclerosis, the complications and treatment. For example, if you just get it like that in any subject, see, for example, if you just get a topic in physiology, for example, sir, you did not explain about the BJ reflex. We did not explain about that one, so this one. So for example, just drop it down in the comment section. I will just explain you. For example, even though if it is already explained in the classes, I don't bother to explain for you one more time. Even if you ask me for 100 times, I am very much happy to explain to you for 100 times. No problem with that. Okay. So don't think like, see, even though we drop it down in the comment section, sir will not. No, don't think like that. For example, some X topic is not being explained in physiology, we just please drop it down in the comment section, guys. Why you feel like that? Oh, why to ask whether sir will explain or not? Why to ask? Don't think like that, right? I'm very much happy to explain to you. Okay, so just write it down in the comment section. Even though I will cover it in the physiology class, no problem, I will explain the topic once again. See, previously one of the doctors had asked me, sir, just please explain a basics about vectors regarding ECG. I explained nearly 1 hour class. I just drop it down in the YouTube session. You just go through it. Vectors, the basis of ECG, why the wave P wave is on the electropositive side, why the Q wave is on the negative side, R wave is tall with short interval, S wave, what is U wave, everything I explained in the ECG. Okay, so this session is about surgery. Don't waste any of your precious time. So even I will not waste your precious time. So without making any wastage of time, we'll just get into the class. Okay, so we will just start with surgery. This is surgery. We'll be getting with the first of our topic, that is endocrinology. We'll start with endocrinological surgery. Endocrinology. We'll start with endocrinology. The first of this kind is breast. Our favorite, breast. So we'll start with the breast topic. Okay, so as you all know the anatomy of the breast, see, you all know the anatomy of the breast, right? So I think no need to explain it, but still for some of the guys who has never seen a breast, I will just explain for them, right? So I think I'm not getting the correct, sorry. Yes, now I got it. Okay, let's keep it like this. Yes, now this is something called the areola. This is the nipple. You have lactiferous ducts here, lactiferous tubules, lactiferous glands, and these glands make a lobule. This is lobule. These are glands. These are glands. These are lactiferous glands. These are lactiferous glands. These are globules, lactiferous globules, and these one are lactiferous ducts, and this one is areola, right? That one is areola. So these are all, see, the globules are also called breast globules, right? The globules are also called breast lobules. So that one is lactiferous duct, and it's connected to ampulla, areola, and all the ducts, right? So this is a normal structure of, see, I'm just doing the basics, right? Now someone is asking about, sir, what is meant by Montgomery ducts? See, Montgomery ducts are nothing but in pregnancy the lactiferous ducts, they get enlarged or dilated. These are actually specialized sebaceous glands that are actually dilated. These are called as Montgomery ducts, right? So we'll discuss the thing in the upcoming chapters. So the basis of breast is, see, this is the basic anatomy. You have breast lobule, you have lactiferous gland, you have lactiferous duct, you have areola, and you have nipple, right? Now this breast, this is clavicle, it rests on the major muscle. That is, what is that muscle? Pectoralis major. Pectoralis major is followed by pectoralis minor, right? So that's all about breast. But what actually breast is? Actually the breast is a modified sebaceous gland. And what is the extension of breast? The breast extends from second rib to sixth rib. Remember, the breast extends from second rib to sixth rib. And when you ask me, it's from medial to lateral. If you ask me from, these are the two breasts, right? If you ask me from medial to lateral, what is its extension? From medial to lateral, its extension is from the lateral border of sternum. This is the lateral border of sternum to mid-axillary, anterior mid-axillary line. So that those are the anatomical extensions from second rib to sixth rib, and from lateral part of sternum to lateral border of substernum to anterior mid-axillary surface. That is the anatomical extensions of breast. Please 1 minute. Please stay on the line. Please 1 minute. Please 1 minute. Right. Just 1 minute. Wait. Yeah. So anterior axillary line. So when we speak about the muscles on which the breast is lying, there are two muscles on which the breast is lying. Please 1 minute. Please stay on the line. Just 1 minute. So okay guys, so welcome. So on which muscles mostly the breast is being resting on? The breast rests on the pectoralis major and pectoralis minor. So these are the two muscles on which the breast rests on, pectoralis major and pectoralis minor. Now if you ask me what actually the breast is a modified sebaceous gland. Breast is a modified sebaceous gland. And we can also say, for example, if you see the mammography of the breast, so obviously sometimes you can see the breast lobules. You can see the breast lobules, and the breast lobules, they empty into the lactiferous duct. through ductules. They empty into the lactiferous duct through ductules. Remember, lactiferous duct through ductules. So how many breast lobules are there? There will be something like 10 to 100 breast lobules. There will be some 10 to 100 breast lobules, right, which empties into the ductule. The number of ducts, lactiferous ducts, if you ask me, it is something like 10 to 15 lactiferous ducts. It's something like 10 to 15 lactiferous ducts, or in some textbooks it is written as 15 to 20. You can take it 15 to 20 as the answer, right? 15 to 20 lactiferous ducts are seen. Now around the nipple there is a pigment. There is a blackish color pigmented area, skin. This very sensitive skin, is highly sensitive skin. This is called as areola. This is called as areola. Now the complete closure of areola during the feeding of a baby is the perfect positioning during the milk feeding, right? Now you can see that the correct positioning of the baby, the correct holding of the nipple by the mouth of the baby is complete filling of the areola inside the mouth of the baby. That is the perfect positioning during the feeding, right? Now areola which is present around the nipple. So this areola, the dark pigment skin present, that is areola. In this areola there are openings of multiple sebaceous glands. There are openings of multiple sebaceous glands. Now during the pregnancy these sebaceous glands enlarge for the lubrication of the nipples. These enlarged sebaceous glands during the pregnancy are called Montgomery glands. Montgomery glands. Montgomery glands. Montgomery glands. Remember, so these are the enlarged sebaceous glands during the pregnancy, and in the areola this is called as Montgomery glands or Montgomery tubercles. Some people will do it as tubercles, right? Now the breast is hanged. The breast is kept in its position by ligaments called ligaments of Cooper. Now if these ligaments are Cooper, if they are affected during the malignancy, the breast shows a dented like thing, or there will be something called dimpling of skin. There will be something called dimpling of skin is observed on the breast if these ligaments are Cooper, are affected during the malignancy. Now what are some of the important things regarding the breast? See, regarding the breast lymphatics, 80% of the breast lymphatics are just drained down into the axillary lymph nodes. 80% are taken down by the axillary lymph nodes, and 20% are taken by 15% are taken by the lateral or internal mammary lymph nodes. 15% are drained into the internal mammary lymph nodes. 80%. So the majority of the drainage is taken into axillary lymph nodes. 15% is into the internal mammary lymph nodes, right? So the majority is by axillary lymph nodes. Now coming to the nipple discharge. This is very important topic, guys. Nipple discharge is very important. Trust me. You will get at least one MCQ from this nipple discharge, right? You don't get direct, but you will get a indirect clinical question in the nipple discharge. Now what about nipple discharge? For example, if you see a bloody nipple discharge, bloody nipple discharge is observed in duct papilloma. Bloody nipple discharge is seen in duct papilloma. This is very important. But if you ask me serous nipple discharge, it is seen in fibrocystic disease. Serous nipple discharge is seen in fibrocystic disease. Then what about ductectasia, sir? In ductectasia, what is ductectasia? It is the dilation of the ducts present in the breast gland. That is called as ductectasia. It's dilation of the ducts. In it you can see any kind of nipple discharge. That is, you may see bloody nipple discharge or you may see serous nipple discharge also. Now what is the actual causes of nipple discharge? If you ask me what are the actual causes of nipple discharge, in nipple discharge, if it is a bloody nipple discharge, the three main causes are duct papilloma, another one is carcinoma, and another one is ductectasia. Duct papilloma, carcinoma, and ductectasia, right? Now out of these three, the most common is duct papilloma. Out of these three, most common is nothing but duct papilloma. Now if you come to serous nipple discharge, the most common diseases are fibrocystic disease, first common, and second one is carcinoma, and third one is ductectasia, and the most common one is obviously fibrocystic disease. Fibrocystic disease is the most common cause for serous nipple discharge. Okay. Now coming to what if in case of other colors? Other colors means, for example, if it is greenish or blackish or something like pultaceous, nipple discharge. Where it is seen, these kind of nipple discharge are greenish or blackish, or generally seen in duct ectasia. Now most of the patients with nipple discharge have benign etiology. Most of the patients with nipple discharge most of the times they have benign etiology. But remember, as a clinician, we have to rule out the malignancy. It can be it can be a benign condition, but obviously you should rule out the malignancy condition also. Now let's consider two cases, right? First of all, we will observe this in two cases. We will just differentiate through two. Now case 1 is a younger individual whose age is less than 40 years and who has a serious nipple discharge, and one more thing is the discharge is coming from multiple ducts. And it is bilateral. There is bilateral cyclical mastalgia, as well as there is no mass. Remember, as well as there is no mass, right? No mass. Now this is one case scenario. Now there is another scenario whose age is more than 40 years, who has a bloody nipple discharge, and it's arising from single duct, and there is a presence of palpable mass. So these are two scenarios by which we can just explain the condition. For example, if you take the two cases, when you analyze it, you can understand the first one is obviously benign. See, I highlighted the first one is obviously benign, whereas the second one mostly it can be malignant. Obviously, through the scenario you can easily understand the first one is benign, the second one is obviously malignant. Hence the first investigation done in case of a suspected case of breast cancer is mammography. The first investigation you do is mammography. And sometimes you will do another, you can do or you might do another investigation called as ductography. So what is ductography? Ductography is nothing but you are injecting dye into the nipple and X-ray is taken. You are injecting dye into the nipple and X-ray is simply taken to carry out ductography. Now ductography, when you will do ductography is done when there is a bloody nipple discharge. Now what are the findings of ductography? For example, the findings come like this. See, for example, the findings come like this. There is a single smooth intraluminal filling defect. For example, the finding came like this, luminal filling defect. Now what you will, obviously the diagnosis is a case of papilloma. And the treatment is, what you will do, the treatment is microdocectomy. Okay, microdocectomy. Now if there are multiple irregular intraluminal filling defects, now what it can be? It can be an indicator of carcinoma. Right. Now if the duct appears dilated, simply you can say it like it is nothing but duct ectasia. Now what is the treatment for duct ectasia? It is Hadfield's operation. Okay. Now previously we just talked about duct papilloma. What is the type of discharge you seen in duct papilloma? Anyone? Obviously it is bloody discharge is seen in most commonly duct papilloma, and serous type of discharge is seen in fibrocystic condition, whereas in duct ectasia you can see either of these. Now always remember, duct papilloma is of benign etiology. Remember. Now let's come to the most important topic, that is breast cancer. Now there are two common malignancies in breast cancer. First one is adenocarcinoma, and second one is squamous cell carcinoma. Right? So there are two conditions. Now this adenocarcinoma, what is meant by adenocarcinoma? Something which arises from glands. and it's most commonly seen in high socioeconomic people. Now squamous cell carcinoma is generally found in people with low socioeconomic status, right? Low socioeconomic status. Now what are the risk factors for adenocarcinoma? What are the risk factors for adenocarcinoma? It is advancing age. If the people are from Western countries, the female belongs to high socioeconomic status, alcohol intake, high fat diet, and one important risk factor is if there is a state of for example, if the patient is exposed to hyperestrogenic condition, hyperestronemia condition. For example, if the patient has if the female has early menarche, or if she has late menopause, or if she is nulliparity, and if she has a late first full-term pregnancy, these all are risk factors for hyperestronemia condition, which may lead to adenocarcinoma. And if you come to the personal history, one of the risk factors of adenocarcinoma, if you take the personal history, she will have carcinoma cervix, if she have carcinoma cervix, if she have carcinoma endometrium, if she have carcinoma ovary, or out of these three, obviously two are going to increase the risk. Any two are going to increase the risk. Now remember one thing, because as the carcinoma of cervix is a squamous cell carcinoma, carcinoma cervix was, it is a squamous cell carcinoma, right? It is not adenocarcinoma, carcinoma cervix is a squamous cell carcinoma, so obviously it is seen in low socioeconomic people, background, right? Now if you take carcinoma of ovary and carcinoma endometrium, they both are adenocarcinoma, so obviously they are found in high socioeconomic status. So that is the reason why you ask the socioeconomic status of a person. See, here only you can understand. You take carcinoma cervix, you take carcinoma ovary, and you take carcinoma endometrium. See, I will tell you the difference. Carcinoma endometrium. In this, carcinoma cervix is actually a type of squamous cell carcinoma, so obviously it comes from low socioeconomic people only, whereas carcinoma ovary and carcinoma endometrium are endocrine, that is they are coming from glands, they are arising from glands, so obviously it's a type of adenocarcinoma, so obviously they will be coming from, or the patient will be coming from high socioeconomic status, socioeconomic family. Right. Now if you ask me, are there any genetic predisposition factors for breast carcinoma? Yes, you can take like BRCA1 and BRCA2. Right. These are the two mutations which may lead to breast carcinoma. Now if you ask me, BRCA1, it's responsible for the most of the malignancies in females, whereas BRCA2, it is responsible for most of the malignancies in males. Okay. It's mainly responsible for occurrence of breast cancer in males. BRCA2. BRCA1 is mostly responsible for occurrence of breast cancer in females. Now, in females, generally during menopausal, they will be given with something called HRT, hormone replacement therapy. Even this may lead to causage of cancerous conditions or malignant conditions. Now, you may ask me, sir, will radiation cause? Yes, radiation exposure also cause, or which may leads to malignancy state. Now, generally, if female given with 40 to 60 gray, this may cause some sort of malignant initiation. For example, generally 1.2 to 2 grays is given generally 5 days a week for a continuous period of 4 to 6 weeks. Now this is a too much dose of radiation. Remember, this is too much dose of radiation. Now some of the doctors are asking, sir, do OCDs and smoking act as a protective factor regarding the malignancy? Of course, maybe. It's not a protective factor, but it is not a risk factor. It may not be a protective factor, but it is not even considered as risk factor also. Why? Because smoking is available in a hypoestrogenic state, and even OCPs may lead to hypoestrogenic state. These two conditions may decrease the chances for breast cancer. Right? Just please be on the line. Okay, so we get a hypohistonic. Now we will do some risk assessment models of the breast. We will do a risk assessment models of the breast. Risk assessment models of the breast. Doctor, I am little bit fast, but don't think like I am going too much fast, because Inicet you must have at least this much of preparations before going to the examination, right? So there are mainly two risk assessment models for the breast cancer. One is Gales and another one is Claus. What is Gales? What is the Gales risk assessment model? So actually this is the most commonly used. Risk assessment model. Now what it includes? It includes number of breast biopsies that are done, and number of first degree relatives with carcinoma breast, and also age at first live birth. What is the age of the female during the first live birth, right? You can just simply remember this with a mnemonic called Nana. Nana. N means number of breast biopsies, A means age at menarche, and N means number of first degree relatives with carcinoma breast, and another A means age at first live birth, right? Now we are coming to the Claus model. It is actually more of information regarding the family history. It is based on the number of decades of life, and the second one is the first and second degree relative with carcinoma breast. And age of the relative during at the age of diagnosis, right? Age of diagnosis, that is all about Claus. But within these two risk assessments, the most common risk assessment model which is used is Gale. Remember, Gale is the most commonly used risk assessment model for the breast carcinoma. Remember, right? Now clearing this out, now we will discuss some of the thing about WHO classification of the breast carcinoma. It's actually the WHO divides breast carcinoma into three types. What are the three types? First one is in situ, second one is invasive, and third one is Paget's disease of breast. These are the three types of carcinomas which are classified by WHO, right? Now coming to the first one, that is, we'll just make a table on this. That is, first one is in situ, second one is invasive, and third one is Paget's disease. So third one is the Paget's disease of breast. First one, coming to in situ, you have two forms. First one is DCIS and second one is LCIS. So ductal carcinoma in situ and lobular carcinoma in situ. So we have two forms of carcinomas in case of two forms into in situ carcinoma. When coming to invasive carcinoma, the most common one is ductal carcinoma. It is the most common type of invasive type of cancer. Second one is lobular carcinoma. Third one is tubular carcinoma. It is the least malignant with the best prognosis. But if someone asks you what is the invasive form of carcinoma with the best prognosis, it's always tubular carcinoma. Remember, it has the best prognosis because it is the least malignant, right? Now it has other forms like mucinous, so colloid secreting type of invasive carcinoma, medullary type of invasive carcinoma, papillary type of invasive carcinoma. Now papillary type of invasive carcinoma is the least common type. Someone asks you the least malignant, it's tubular cancer. Least common is papillary invasive carcinoma. Metastatic. And what is the most malignant with the worst prognosis in invasive? That is IBC. Invasive breast carcinoma, that is the most malignant with worst prognosis. Okay. Now the final one is Paget's disease of nipple. We'll discuss that one later. Now we'll first discuss about the rest of the things, right? We'll first discuss about the rest of the things, right? What happens is in females, in female breast, there are both ducts and lobules. Whereas in males, only ducts are present. So lobules are absent. So that is why males may show ductal carcinoma, but males will not show lobular carcinoma. Lobular carcinoma is exclusively present in females because they have lobules. Males don't have lobules, right? So ductal carcinoma in situ and invasive ductal cancer are found in both males and females because ducts are seen in both males and females, whereas lobular carcinoma is extensively seen in females, right? In a patient having lobular carcinoma in situ, since it is actually multicentric and bilateral, it increases the chances of bilateral breast cancer. So that is the reason, because lobular carcinoma is mostly, it is multicentric and bilateral, right? Now if you take ductal carcinoma in situ, it also increases the risk of ipsilateral breast cancer. Now let's discuss each breast cancer one by one. First of all, you take DCIS. Now listen carefully guys, everything becomes something okay from right now. So DCIS means ductal carcinoma in situ. So actually what it does is it increases the risk of ipsilateral. This form of cancer, it increases the ipsilateral invasive ductal cancer, and it can be seen in both males as well as females. Now what is the pathology? Now DCIS, regarding the pathology, it can be classified into nuclear and nuclear grade and depending on the necrosis also, right? So it can be classified on the basis of nuclear grade as well as necrosis. Now regarding the nuclear grading, it can be taken as low grading and high grading. So low grade DCIS and high grade DCIS.